All right, guys. Matt, how you doing?
Anthony.
Chris, how you doing?
Good.
Chad?
How am I doing?
Where were you?
How am I doing?
Where were
I've been out having snacks.
So we're good here. We have, the way the MedEd Combine works is we have two hosts on each time, a physician like you saw in the last one, and a representative. So out there, if you have any questions, please ask us the questions you have. We want to answer them for you. But we're going to get started here with the VYRSApro, showing how to do some SI joint fusion. I think we're going to show a few different types of things here. So you guys tell us where you want us and where you want us to go. You have control of the slides. We'll get started there.
Thank you.
Step on up and
Anthony, thank you. Dr. Stevens, Dr. Jafreda, MedEd Combine, thanks for having us today. On behalf of VYRSA, I'm Dr. Peter Przypolkowski. I'm a anesthesiologist, interventional spine specialist in the Philadelphia area. So I appreciate you guys having us here to show you some techniques for SI fusion. So we'll start with the slide deck. So what are the indications for use for SI fusion? Typically in the pain space, we're very good at managing symptoms. You know, there's not many procedures we do that actually cure patients. So this is one of the few procedures I do where patients come back and they give me a hug and they say, I'm probably never going to see you again because you fixed me, right? And that's a great feeling as a physician. You know, it's nice to do nerve blocks. It's nice to do procedures that help take the edge off for a couple weeks or maybe a month. But when you change someone's life and you cure them of their low axial back pain, it's SI mediated. It's unlike anything, and this is one of the few things I do to actually cure low back pain that's SI mediated. So my typical patient's a patient who had an L5-S1, maybe an L4, L5 fusion, still has low back pain, some radiation into the groin, radiation into the hip, radiation down the leg. Not neuropathic, not radicular, none of those descriptors. It's typically a dull aching pain. In terms of physical exam findings, you know, it's a positive Faber test, especially in New Jersey, Philadelphia with all the payers. We have to document a really good physical exam to get both diagnostic, therapeutic, and/or SI fusion procedures covered. So after my physical exam findings, I typically, like you guys do a diagnostic block. At least for me, I'm looking for 80% relief. Some of the insurance carriers are looking for at least 50% reduction in pain, no matter what the time frame is to consider SI fusion.
Doctor, is that slide on the bottom right, is that there to demonstrate the difference between the pressure differential coming from a fusion down from an SI joint going up, or what is that picture for?
The estimates between what the incidence of SI joint pain is for patients that have low back pain.
Low back pain presenting, Chad. So
okay.
Anyone from 15 to 40% of patients who are presenting with low axial back pain could be SI joint mediated.
Okay, thank you.
Good question. So why SI fusion? Like I said before, we're very good at doing diagnostic blocks, therapeutic blocks in the SI joint, right? We own, as interventional pain doctors, the posterior approach to the SI joint space, right? We're very good at accessing the space. We're very good at putting contrast dye into the space. This is the same approach we use with the VYRSA SI fusion system. It's a posterior approach into the SI joint. It's something we're all very familiar with as pain doctors. It's been in use since 2014. I didn't know that because, you know, a lot of these newer companies are coming to market.
Right.
SI fusion's kind of new for interventional pain doctors, but in the ortho spine world, VYRSA's been on the market since 2014, which is great to know. We've had a lot of orthopedic colleagues been using this device for 8 years now and getting good outcomes. It's been proven to stabilize the joint. We know it's supposed to be a fixed joint, right? The reason people have SI joint pain is because the joint's no longer fixed after a 4-5-5-1 fusion. So now this procedure, this allograft, provides fixation, provides a fusion, you know, out here. And like I said before, this procedure, it's well suited for us as pain doctors. It's a 20 to 30 minute case. It's an outpatient procedure, no general anesthetic. I typically use a little bit of VYRSA and fentanyl, a lot of local anesthetic. In terms of the graft, it's a large graft window, which is great. We do place DBM in with the graft window. It's a low profile. The reason I like the VYRSA product, we have different implant sizes. Not everyone, you know, is the same size when it comes to SI joint articular cartilage and how much surface area is there. So it's nice to have options in terms of sizing allograft before we do the fusion procedure.
So in comparison to some of the other companies in this space, what we have is an implant that was custom made specifically for the SI joint, whereas there are some bone dowels and pliffs that other companies utilize. This is specifically for that joint space, and we get more surface area across the joint with this implant, but the same low profile insertion that you can expect with many of the other implants.
Good point, Matt. So as pain doctors, I was never told about fusion, right? This is all kind of new to me. And it's very important, I think, as pain doctors that we're educating other providers who are doing SI fusion that we're actually doing a fusion, right? We're not putting allograft into an area where the ligaments are in the sacroiliac joint space, that we're actually decorticating cartilage, going deep enough to decorticate cartilage. And I'll show you when we work on the VYRSApro model here, what that looks like. If you look at the slide, specifically down on the right-hand side, you see a little red dot. So that is where the sacroiliac ligaments are. And we want to make sure we're going through those ligaments, getting into that green zone there, into the actual cartilage bed, decorticating that cartilage, making a bleeding surface before we put the allograft, right? So if you do a good decortication, you get a good bleeding bed, you put allograft in with DBM, you're going to have a successful fusion.
I think that's a great point, because I think maybe because Versa's from the orthopedic background, I didn't know much about this with the SI joint when I was just doing injections. As I've learned it from people, you know, Versa, where that real cortical, where that fusion we want to put is in a different spot than I think most of us thought. It's really that inferior area. And I will get to it when we do the procedure, but this is one thing that really drove home to me that, hey, this has a good chance of doing a fusion. We're doing what we would do in the spine for a fusion, right? We're doing what we would do in different areas for a fusion. So that was very interesting to me.
And that's a good point, Anthony. I mean, I think we're used to doing this posterior approach, lateral to S2. You're not really getting down into that articular cartilage bed, right? You might be more into these ligaments, right? We want to make sure we get into that bed because we know we're going to get a good fusion. In this approach, it's more of an inferior inlet approach that I'll go over, whereas some of the other SI fusions was more of a lateral approach, lateral to S2.
Yep.
So speaking of approaches, you look at the approach here. You know, if you look at compared to the right, really not getting down into that articular surface of the cartilage to do a good decortication and fusion here. If you look at the approach on the left, which we use with Versa, it's an inferior inlet approach. Allows us to really get into that bed, decorticate a lot of cartilage, create a nice bleeding bed. It's going to make a nice bed for fusion of the sacroiliac joint space.
And this is how you guys do your injections, correct? I mean, that inferior inlet approach is how I always, I mean, once in a while I'll go superior, but 95, 98% of the time, this side, yeah.
Yep, day in and day out. So this, like I said, as interventional pain doctors, this is the space we own. This is the approach we're used to. And it makes sense to do an approach in terms of SI fusion that we've been doing for years out of our fellowship as pain doctors.
So in addition to the approach, you can really see that the inferior inlet approach allows for more surface area coverage in the joint space with our implant.
Like I said, we have variable anatomy, so not one size fits all when it comes to SI fusion. We have different sizes of allograft. It's a nice large window, low profile. I typically put DBM on both the anterior surface of that, posterior surface, and into the graft window when I do my fusions. And we'll show you on the cadaver, on the VYRSApro model here, how you can size the different types of allograft.
It looks like your graft windows are pretty constant on no matter what size the implant is. Is that true?
Just the length that changes.
Okay.
Correct.
What's the difference, Matt, from the smallest to the largest? How much DBM?
Same amount of DBM.
Okay.
Right? It's just a different length of the implant. And so we gauge that intraoperatively, and it ranges from a 20 millimeter length up to a 35 millimeter length. Okay. And with our inserter that you'll see here, we could actually do 2 implants if we wanted and get up to 55 millimeters in length into that joint. Okay. Cool.
So sample case, you can see here, it's more of that traditional inferior inlet approach into the sacroiliac joint space, covering all that green area, which is the articular surface of the joint. You can see an AP view there on the right side, kind of that river view, a little bit oblique to the left for the right SI fusion. So the reason I like it, it's an approach I'm used to as an interventional spine specialist. It's an approach that I've been doing forever, so I feel very comfortable doing it. And like I said, these cases, a little bit of fentanyl Versed, outpatient procedure, 20 to 30 minute case. Outcomes are great. Patients come back very happy.
One thing I want to point out here is the lateral. See where the green circle is, right? A lot of people, for some reason, think the SI joint ends with the sacrum ends. That's not true at all. And what we started doing is we're doing arthrograms. When we do our SI joint injections, we never used to go lateral. But now we're doing it, putting that contrast in, and seeing that loop around. It's pretty interesting. My fellow's actually going to be writing a paper about it, just about arthrogram of the SI joint. So a lot of people think it's a danger zone for some reason, but you got to think you're going lateral, right?
Correct.
You're going lateral. You're going past the sacrum per se. But that's not the end of the SI joint.
Yeah, and I think, you know, at least when I was taught, that was like the safety zone not to go past that ventral border of the sacrum. But it is safe to go past that because we know that's kind of really the bed you want to be into to get a good fusion.
Awesome.
Yep.
Great. So with that, we'll
Let's do the procedure.
head over to the BioTrust model here.
So while you're getting ready for that, so you talked about how pain doctors are new to the fusion space, right?
Yep.
One of the things that I found with spine fusions and this SI fusion world is follow-up, right? Surgeons are very quick to follow up their patients at a month, at 3 months, 6 months, and check the graft completion and the graft maturity. Do you do anything to follow up your implants to see if there's actual true bony surface fusion? Or do you just kind of go by patient satisfaction or outcomes? What do you go by?
Yeah, so to be honest with you, Chad, so I'll see the patient 1 week post-op just to make sure there's no signs of infection. It's not a big incision we're making with this procedure. I have not yet ordered any follow-up CT scans to see if fusion's occurring.
Okay.
For me, it's patient-reported outcomes,
Okay.
right? So what I'm seeing now is the patients I've fused their right side
Yeah.
are now coming back 4 or 6 months later saying, hey, can you do my other side?
Okay.
So for me, the proof is kind of in the patient
Right.
outcome and the
Okay.
fact they're coming back requesting me to fuse the other side. I think it's kind of proof in and of itself.
Yeah.
Yeah.
Okay.
And the fusion's not going to occur typically for at least 12 months.
Okay.
So those CT scans are something that we're looking to do to collect data in the near future, something we're currently working on.
And you guys would be at 1 year looking at data? Is that
Yeah,
what you're
I
going
mean,
to
you
do?
could look for it at 6 months, but typically you're not going to see true fusion until 12 months
Right.
later.
No, that's correct. But my point is that I know that after you do a spine fusion case, close follow-up is documented for these purposes so that you can prove to insurances and to other people that we do get true fusion by 6 months. So we do get true fusion by 12 months. So I think that's good to have that data collection.
Something we're working on, and also the other companies in this space will be looking to publish fusion data.
I agree.
Good.
I agree 100%, especially with the activity right now going on between surgeons and interventional spine docs.
Yeah.
I think we need to get that paradigm. I see my patients just like my spine. I work with spine surgeons, right? I see my patients for any fusion device I do just like my spine surgeons do. I brace them. I see them at 2 weeks, 10 days to make sure there's no infection. I see them at 1 month, 6 months, 12 months, all of them.
Yep.
And we get x-rays. We don't get CT scans. Same with spine. We don't get CT scans unless we don't think there's a fusion
Okay.
or we think there's a problem.
Yeah.
Because there's a good amount of radiation with this.
Yeah.
That's the one problem with the study with the CT
Yeah.
scans.
Yep.
We'd love to do a 12-month study for spine
Yeah.
too, right? But you know, you got to say, hey, we're going to dose you with a bunch of radiation just to see if it fuses.
It's like 150 x-rays to take
Yeah.
a CT scan.
Sometimes, yeah, even more. So I do think for all, this has nothing to do with Versa, but all of interventional spine out there, we need to start getting those algorithms and acting like surgeons. Pre and post-op, how we do it, you know, take care of these patients just like a surgeon would. And a lot of that noise or stuff we're hearing from orthopedic surgeons, neurosurgeons could start to go away. We need to start working with them, working with their algorithms to see what I can do. And I think you guys, coming from the orthopedic space, can help bridge that gap. So that would be excellent. Let's get started.
Yeah,
Let's do the
show
fun
us your
part.
stuff, man.
Let's do the fun part.
Perfect. All right, so the approach with Versa, like I said, it's an inferior inlet approach. So we're not just going straight posterior lateral to S2 with some of the other companies. We're actually taking more of an approach going from the inferior aspect of the sacroiliac joint space to the superior aspect of the space. So the case is all about stymon pin placement. If you have the pin placed in the correct location, the case goes very quickly, very smoothly, very efficiently. So typically what I do is I localize with 1% lidocaine with epinephrine to the skin. I place my stymon pin in that inferior to superior fashion into the joint space. I'll take an x-ray. And sometimes I go a little bit from medial to lateral to make sure I'm in the space because I'm going to run up against the ilium. I know it's not going to go any further lateral. It's going to hit the iliac crest. And what I'll do at this point is I will go to a lateral to see what my trajectory looks like.
It's important you always look at 2 views, isn't it?
Yeah, so this is a 2-view case. It's the inferior inlet view, Chad, and then it's this lateral view.
Absolutely.
There we go. Great, thank you. So this is that inferior inlet approach, right? So Anthony, you know, we spoke about I could go a little bit deeper, ventral to that aspect of the sacrum, right, to really get in that bed. But this is the ideal approach, right? So it's inferior inlet. getting good trajectory. I would never go further. You know, I can advance a little bit further. I'm not going to go past the ala. X-ray.
You're good where you are.
Good.
Yeah, and I think if you can see on this picture, you can see that little circle there we're talking about, or oval shape we were talking about that goes past the anterior part of the sacrum.
Good. So once we got the Steinman pin, and like I said, you know,
That's the case, right?
That's the case.
Anyone
it
can
really
do it,
is.
yeah.
Anyone can do it. This is the approach you're used to as a pain doctor. So Steinman pin placement's key. Steinman pin placement's everything. After we put the Steinman pin in, I usually make an incision, both in front of and below the Steinman pin, once again with 1% lidocaine with epinephrine. We then have a joint finder. Everything in the kit comes identified as whether it's the sacrum or ilium. So it's very easy to make sure that you're putting sacral side to sacral side, ilium side to ilium side.
Even a doctor can figure that out.
Yeah, any doctor can figure it out.
First part of the procedure.
That's right.
Make sure you put it in there.
Joint finder. Good.
I like this joint finder too because that gives you a secondary. You know, we always have that in our back of the mind. Hey, how could this go awry? And maybe someone has soft bone and you place the bone and it went through the ilium or something.
That's right.
With the joint finder, it's not sharp at all. It's blunt, right? So you're going to
Correct.
get into that space, and once you get locked in, then 100% you know in the joint. No
Excellent.
worries at all that you're putting it in the ilium or the sacrum.
Well, he's also going from medial to lateral.
Yes.
X-ray.
That looks great.
X-ray.
And see how we are past that anterior border of the sacrum. And that's where we want it, Matt, right? That's where that cartilage is.
Exactly. Yep. So we got a little bit on both sides of that anterior sacrum line that shows up
So the
very
pin
clearly on a fluoro, but you can see the shadow of where the joint extends below that.
So
kind of like on that
next
side.
part of the case, we take the Steinman pin out from the joint finder. Once again, you have identified sacral side, ilium side. So sacrum side goes to sacrum side, ilium side goes to ilium side. And with this X-ray.
Very nice.
That's good.
X-ray. Good. So joint finder will then come out here. Take the slap hammer.
Top there.
So we use a slap hammer now to take out the joint finder.
This is my fellow's job to do the slap hammer.
Yeah, and so I do recommend when you're using a
I
slap hammer.
hold the bottom.
Yeah,
He
and,
does,
and put some gauze
He's
around.
tall.
Yeah.
Put some gauze around
He's
the
tall, yeah.
incision on the skin because you do get a little bit of bleed back
Yeah.
when you're using slap hammer. You can get all over your, all over your lead.
So in this procedure, you get to use a hammer,
And a slap
hammer, and a drill.
Yeah.
Yes.
I'm sold.
Yeah, exactly.
I'm sold. That sounds like fun.
Drill guide.
Next, we put in the drill guide. And it's a T drill we use here. I don't use any power tools yet, Chad.
All right.
I'm still using, just brute strength.
Oh man, that's great. You have brute
Go
strength.
live. So under live is where I'll really...
And there's a drill stop too, correct?
There is.
So you can't go too deep.
There you go. That's good.
Good. Stop. So there's 3 holes here that we're going to drill in. This is the first. This is the middle hole. Go live.
Stop there.
Good.
Nice.
Last hole here. Go live. So I'm always drilling under live to make sure I don't go any, further through the ala. Good. Stop. Thank you.
Just like the other button.
T handle comes out. So this is where we have
And what's the name of this? The box cutter?
box
Box
cutter.
cutter, we call it the decorticator because
I like it.
The drill
Yeah.
is going to churn up that cartilage and that space and start to clear a path. The decorticator is going to bring all of that up and put a neat space for our
And that's important, right? So that drilling is creating a really good bleeding bed, Matt, for our fusion to take place. Box cutter is going to clear away some of that cartilage, that bleeding bone for us. Shot. Shot. Shot.
You also know they're from the orthopedic space because they
Shot.
usually bring the biggest hammer.
I love big hammers, man.
Shot. Good. So we got the box cutter. I'll
There
go
we
a
go.
little bit further. X-ray. Perfect. So
And
box-
Matt, is that where your implant's going to end up?
Exactly.
Yeah.
Yep. And you can see that the box cutter is kind of like a representation of our smallest
That's
implant.
nice. Yeah.
So you can kind of get a size gauge from that as well. So just you can remove that. Yep.
Once again, slap hammer. Take the
Slap
box
hammer.
cutter.
Twice.
Oh,
It's hammer time.
satisfying.
We play MC Hammer in the ER when I'm doing
Oh,
these cases.
cool.
It's
I like
hammer
that.
time.
MC Hammer was somebody from a long
Yeah,
time ago
that's
for
true.
those
I know.
youngsters.
It's crazy, isn't it?
So this is great to show though. All this in here is what you're decorticating, and you can see it.
And that's precious. So I will actually mix that, Anthony, with my with DBM, right?
So I don't know if you guys can see it on the close-up one here, but that'll be full of nice, good stuff that you actually want to put back in there sometimes. I mix it with the DBM. I put it in front sometimes of the implant as well.
We have different implant sizes, like I said. This is one of our longer constructs. The nice thing about this company is we have different types of allograft in terms of their constructs and how long they are, which really helps with variable anatomy of the SI joint.
What do we use to size it? Is this it? Or is this by eyeballing the person or what?
If you look at the cannula, right, and you can see here on the screen that long tine on top.
Okay.
So we have two cannulas, one for the right, one for the left.
Okay.
Long tine's always going to be on top. That long tine is 35 millimeters long, which is the size of our largest implant.
Okay.
Right? So depending on how much space you have in that joint, because as you know, highly variable anatomy, you can have a different shape to the joint here, you can have a different size joint, you might also be coming in from a slightly different approach, just depending on how the case went. You can gauge out how much space you have and dictate which implant you want to go in with. In our opinion, it's always with the goal of putting as much surface area across the joint as possible.
I like that,
right? And another way this factors in is that if maybe your approach is a little bit off for whatever reason, maybe you have funky anatomy, maybe you have a really tiny joint, maybe your cannula is sitting a little bit not flush with the joint, but a little bit outside the joint. As you notice with those drills, our drills extend far beyond our cannula as well as the box cutter. And what that can allow you to do is get deep into the joint space where you want to be, and then potentially put a small implant after it, which we're going to tamp down into that extended space just to make sure it is fully inside the joint and not sticking out at all.
Good.
Right?
Yeah, that's key.
Like
We've
Matt
all
said,
seen some pictures of people that went outside the joint.
is it
Exactly.
You know, I see a lot of stuff posted on LinkedIn, unfortunately, and if I was that physician, I wouldn't be posting it because some of it's not even in the
I always
joint.
wonder about that. What are the bad ones that they're not posting?
All right.
Yeah.
So we've got a nice implant there that's actually painted with.
I was gonna say, is this radio?
We'll be able to see it.
We'll be able to see it.
I'm
once it's
excited.
done.
Very nice.
Shot.
You get excited pretty easily.
I did.
Yeah.
It's a little
Shot.
Chad.
Good. Yeah, so this implant we'll be able to see.
So the implant has now been delivered outside the inserter, and then we come in with a tamp, and we can drive it a little bit forward as desired.
So we know our lateral view is perfect.
This is just a tamp to, once again, make sure the allograft goes where we need it to go, and we're covering a lot of good surface area. Take a shot there for me. Great, and go live.
Look at that. That's
Perfect.
pretty cool.
Stop.
Yep.
Great. And then what I typically do is I just take everything out in one fell swoop.
Very nice.
So I do 2 Vicryl deep, some monochrome in the skin, and that's pretty much it. So 15, 20-minute case, inferior approach. It's a nice approach to this space.
Do you give an SI joint brace?
I do.
Flip around
You
back
do?
to
So do I.
an AP.
Yeah, back to an AP.
I think we need to start doing that for all fusions. You know, you ask a surgeon, L4-5, L5-S1 fusion, do you give a brace?
Yeah.
They brace everybody.
They look at you and they say, what do you mean, do I
What
give
kind
a
of
brace?
questions?
Yeah, I mean, like you said earlier, right? We have
If
to
we want
kinda-
a fusion.
Exactly. You want a
Yes.
fusion, you want to make sure that they're following the post-op instructions you're giving them, right? To give them a fusion.
Yeah.
Other thing that I like about this, right, when we're talking about allograft,
Nice.
we're not burning any bridges, right? The nice thing about Versa, they have a
AP?
An inlet view.
they have
Leak your way.
they have a screw too that we can place in from a lateral approach, which is nice. So some orthopedic surgeons are putting a screw
Do you want
in.
to show that real quick?
Yeah,
We
I'd
have
like
2 minutes.
I'd actually love to show if we can rotate the arm back to an inlet
Oh,
view.
tilt to the feet.
Back to like a caudal tilt.
Back.
Yeah.
What do you want? You want
This one.
to the feet.
There you go.
How many pain
About
positions does it
30,
take to move the C-arm?
That's good.
Yep. Nice.
So if you refer back to that slide that
Stay
we
on.
have
Stay on screen.
on the cartilage surface,
Yeah.
right? Next one.
This one?
Yeah, so you see that image on the right where the joint is. That lines up nicely with what you're seeing on this floor here.
Exactly.
And you're in the joint. You're not in, the ligaments, right?
Yes, and
You're in the
inferior
joint.
aspect of the joint.
That's great. So do you want to, I know you have this here preloaded. Do you want to show this real quick?
Sure.
We can take this one off. I'll take that. Thanks, Sam. We'll give it to the BioTrust people to fix up.
Sure is handy having them here. Perfect.
Yeah, we got 1.5 minutes. We can
Well,
show it,
under
though.
the gun.
So that's too long,
That's too long.
right?
Take a shot.
Just take a shot. So that's what the screw looks like. You give me a lateral too. So that's the AP view of the screw. Orthopedic surgeons that we work with are typically doing a screw along with the posterior allograft to really get a good fusion. You know, I'm not sure everyone knows out there, but this code was kind of up for review it was up for review on Thursday, and it looks like we might be heading to a T code here.
That's the posterior code.
That's the posterior code, correct.
So we'll be using lateral first.
We might be. So that's TBD, right? To be determined. But it's nice to know you're working with a company that has both a posterior fix and a lateral fix in case you need it.
And I think, you know, we have Versa come back next time, we show the lateral.
Yeah,
What
Absolutely.
do you guys think? So this is a little teaser for next time.
Yep.
Thank you very much, guys. This was excelled. Very educational.
Nailed
The
it.
procedure went
Nailed
perfect,
it.
too.
Thanks, Anthony.
Very
Chad,
nice.
appreciate it. Thank you,
Great
man.
job.
Thank you, Matt.